Imagine prepping your patient for a critical procedure, only to have the anesthesiologist halt the case at the last minute. The culprit? A routine preoperative blood test. Across surgical wards, there is a pervasive habit, refusing to clear a patient for the operating room until their platelet count hits exactly 150,000 per microliter. But that 150,000 figure is a statistical population baseline, the lower end of a standard laboratory range. It is not a biological requirement for stopping a bleed. Rigidly adhering to this lab number leads directly to canceled surgeries, prolonged hospital stays, and the use of blood products that the patient may not actually need. Contemporary perioperative management requires us to move away from universal lab thresholds and toward a risk-based, procedure-specific approach. A patient's actual risk of hemorrhage is determined by two specific variables: the anatomical location of the surgery and the underlying function of the platelets they have. We need to replace the 150,000 myth with a precise, evidence-based algorithm for surgical clearance. Prioritizing a lab report over physiological reality introduces clinical friction, often resulting in management decisions that do not reflect the patient's actual hemostatic needs. This view shows the mechanical role of platelets. When an endothelial breach occurs, these disc-like cells clump to seal the fissure, initiating primary hemostasis. Beyond this physical plug, they also serve a vital biological role. The surface of these activated platelets provides the necessary area to trigger the broader coagulation cascade. However, a mathematically normal platelet count can provide a false sense of security in patients with underlying dysfunctions. Look at this comparison. On the left, antiplatelet therapies paralyze aggregation despite high quantity. On the right, a lower quantity of active, interlocking platelets successfully seals the gap. Systemic conditions like uremia or inherited disorders create similar dysfunction. A patient with a highly functional count of 60,000 presents a lower bleeding risk than a patient at 150,000 whose platelets cannot aggregate. Counting platelets without verifying their ability to actually form a clot gives an incomplete clinical picture. An adequate numerical count cannot guarantee hemostasis. Qualitative function must always be factored into the clearance. This chart outlines the American Association of Blood Banks guidelines for stratifying surgical thresholds. The wide base represents our lowest required count for safety. For major non-neuriaxial surgery, including orthopedic fracture fixation and arthroplasty, the minimum required platelet count is 50,000 per microliter. Once a patient meets this 50,000 baseline, routine prophylactic transfusion is not supported by current clinical evidence. Moving up the pyramid to neuroaxial anesthesia, the baseline threshold requirement increases. Epidurals require 70,000 to 80,000 platelets because the specific risk of an epidural hematoma carries severe neurological consequences. There is a distinction here. While epidurals require higher counts, select spinal anesthesia cases can proceed at the lower 50,000 mark. Finally, we reach high-risk closed-space operations, such as neurosurgery and ophthalmic surgery, requiring 100,000 platelets per microliter. In these anatomical compartments, a hemorrhage of just 5 cubic centimeters can result in fatal intracranial pressure or irreversible vision loss. These precise requirements demonstrate why a single 150,000 roll is an inefficient way to manage surgical risk. Acceptable platelet levels are dictated by the specific anatomical compartment's ability to tolerate a microhemorrhage. Let's apply this to a specific case. An orthopedic trauma patient arrives with a borderline platelet count of 60,000. While that number technically clears the 50,000 threshold for the surgery itself, the traumatic context requires a deeper look. We evaluate complex patients using this 4-pillar bleeding risk dashboard. First, check the coagulation profile. Verify INR, PT, and fibrinogen to ensure cascade functionality. Next, assess patient factors. Conditions like liver disease or infection can erode hemostatic stability despite viable platelet counts. We also account for surgical factors. In trauma, massive fluid resuscitation often leads to dilutional coagulopathy, thinning out the effective clotting agents in the blood. While surgical tools like tourniquets reduce visible bleeding in the field, they do not resolve the patient's underlying systemic coagulopathy risk. Surgical clearance is not a single variable equation. It requires balancing all 4 pillars of the patient's hemostatic profile simultaneously. We can distill current hematological guidelines into a 3-tier clinical decision algorithm. Any count above 100,000 per microliter puts the patient in the green zone, clearing them for virtually all surgical and neuroaxial procedures. The yellow caution zone, from 50,000 to 100,000, requires active risk stratification rather than an immediate reflex to transfuse. The red line for major elective surgeries sits below 50,000. Here, intervention, either a transfusion or delaying the procedure, is necessary. This leads to a core principle of perioperative management: transfuse based on clinical necessity, not laboratory numbers alone. Unnecessary platelet transfusions introduced by protocol anxiety rather than patient need can result in adverse physiological reactions. To safely clear your patients, verify platelet function, confirm the coagulation profile, and analyze the clinical context. Using these specific thresholds allows the clinician to move past simply reading lab reports and begin actively managing patient-specific safety.